I've said it before and I'll probably say it again, but surgery can be a cruel mistress. I've done a great operation, the x-rays look fabulous, and the patient is so happy to have had their new hip. What could possibly go wrong? Well, out of the blue comes a phone call from the nurses a week or two later. I've got Mrs. X in clinic and the wound is leaking. What would you like us to do? I feel like I've been punched in the guts. But I put my brain into gear and make a plan to deal with it. Where do I start? Well, the first thing that I need to do is to see it for myself. I have to know whether this is just a bit of inflammation in the wound edges or if it's something more serious, such as a deep infection. This is very uncommon, but it needs to be identified and dealt with promptly in order to save the hip replacement. That sounds dramatic, but the stakes really are that high. When we assess a medical or a surgical problem, we do three things: take a history, do an examination, and order appropriate investigations. Taking a history means asking questions about the problem, such as when it started, how it's affected you, and checking to see if there are any risk factors that have made it worse. The examination starts as soon as I see you. How do you look? Are you showing signs of being unwell, such as sweating or a fever? I examine you and the wound, looking to see if there's bruising, redness and swelling. Look away now if you're feeling a bit squeamish. This is a wound where there has been bleeding under the skin. The pressure has caused the wound to open up a little bit. What's coming out of the wound and where is it leaking from? These are all important clues in deciding what to do next. I'll arrange some blood tests to see if the inflammatory markers are raised. These are the white cell count, the erythrocyte sedimentation rate, and the C-reactive protein. If all of these are way above normal, it means that there's an established infection. They're also useful as a baseline so that we can monitor the effect of any treatment that you might have. The next step is to have an ultrasound scan. The radiologist runs a probe over the wound to see if there's a collection of fluid. We need to know if it's superficial, that's just under the skin, or deep within the wound and connecting with the hip joint. The radiologist can also see if there's evidence of infection around the collection of fluid. All of this information helps me to decide what to do next. If it's just a bit of bruising and inflammation, then you'll have a short course of antibiotics to help reduce the risk of it turning into an infection. I'll keep a very close eye on you to make sure that the wound goes on to heal without any further problems. If there's a large collection of fluid under the skin or it's deep within the wound and involves the hip joint, then I'll have to wash it out. You need to be admitted to hospital and have surgery to open up the wound, clean it all out and change the head and the liner of the hip replacement. We'll give you powerful antibiotics for several weeks, sometimes intravenously, and monitor you very carefully. If the infection doesn't go away, I might have to remove the hip replacement completely and start again. The risk of this happening though is very low, well under 1%. So why do wounds cause trouble sometimes? Well, some people are more at risk, particularly if you have a lot of fat over your hips or if you're a diabetic or taking steroids. Lots of patients with arthritis take anti-inflammatories like ibuprofen, and people with heart disease often take aspirin and anticoagulants such as apixaban or rivaroxaban. These drugs increase the risk of bleeding. The other thing that we do is to give you medications to thin the blood within a few hours of surgery. This is to reduce the risk of you getting a blood clot, a deep vein thrombosis or a pulmonary embolism. Surgeons take great care to make sure there's no bleeding inside the wound before we close it. But inevitably there is always some oozing. The blood thinners stop the ooze from clotting, and this can cause bruising and swelling, which delays wound healing. As always in surgery, it's a matter of balancing the risks and the benefits of the procedure and the medications that you take. Sometimes it's more art than science. I'll discuss all these things with you when you first have your consultation with me. Don't forget though that the vast majority of people have no problems at all with wound healing. It usually takes a couple of weeks for the wound edges to heal up properly, and after that the wound can be a bit itchy and uncomfortable for a while, but it's only a few weeks, and that's quite normal. As always, if you'd like to know more, then please get in touch. Thanks for watching.